implant used for fracture neck of femur, fragments are compressed intraoperatively. This means essentially healing is by compression method, primary healing by absolute stability. However, current implants allow sliding movement. Mobility is contrary to AO principle of primary healing by absolute stability. When fracture humerus or any other bone treated by compression plating, do you allow mobility of the fragments? No. Then why violate the principle only for fracture neck of femur? Is sliding movement the cause of non-union and AVN? I believe yes. Primary healing and mobility. There is neovascular ingrowth from the distal fragment, which has an abundant blood supply. There is also creeping substitution. These two processes are microscopic processes. They do not tolerate any mobility. Sliding mechanism is the cause of excessive collapse, which leads to non-union and AVN. Why sliding movement is the cause of non-union and AVN? We have to do some biomechanical study. When we stand on one leg, there is a tremendous force acting on the hip, which is at an angle of 16 degrees and to the vertical line. This is 16 degrees. Now, here in the first picture, the fracture is transverse fracture. When there is transverse fracture and weight is there is 100% compressive forces and 0 shearing forces. In the second picture, the fracture is vertical and therefore there is 100% shearing forces and 0 compressive forces, which occurs in Powell type 3. And in Powell type 2, there is a combination of compressive and shearing forces. In the picture, you can see that there is a 16 degrees of angle and the force is at right angles to the fracture line. And here, the Powell's angle is 106. And therefore, the force acting is parallel to the fracture line. And therefore, there is 100% shearing forces. Now, put it graphically, when there is 16 degrees Powell's angle, there is 100% compression and 0% shearing. And as opposed to that, when there is 106 degrees, there is 0 compression and 100% shearing. In between, there is a combination of the two. At 61 degrees of Powell's angle, there is 50% of compressive force and 50% shearing force. Shearing force is the cause of non-union and AVN. Evidence. Robust evidence is valgus osteotomy for non-union. Despite 1 year of non-union of fracture neck femur, with lot of fibrous tissue between the fragments and absorption of bony ends and a gap, the union rate is 94% and AVN is 10%. Shearing force is converted into compressive force. Therefore, compression reduces the shearing force. This is an example where there is a 90 degrees of Powell's angle, and this was treated with just 3 lag screws and compression was achieved and the fracture united. Also, the shaft fracture united. For healing of fracture neck of femur without complications, the mantra is to optimize compressive forces, minimize shearing forces, and absolute stability. This is probably the solution. How to achieve this mantra? One is anatomic reduction, choice and placement of implant by inserting lag screws at right angles to the fracture line for optimum compression and minimum shearing forces, methods to provide absolute stability. Now, problems of both DHS and 3 cancel screws. Large number of meta-analysis, RCTs, papers have shown sliding mechanism causes excessive collapse, which leads to healing problems like non-union AVN, neck shortening, which results in changed biomechanics of the hip and symptomatology. Reoperation rate is 20 to 30%, which is unacceptable. Why the lateral fixation is unstable? This is because when we insert a screw, we create a gap between the shaft of the screw and the cortex, and this gap goes on increasing because of the thin, weak cortex, and this gap is the cause of toggling of the screws and 30% displacement. And what is the solution for this? Sleeve has three functions. One, the sleeve closes the gap, fulcrum is medialized, as you see here, and prevents toggling and stabilizes the lateral wall. GSKT system is based on truss or triangle principle to provide compression and absolute stability. What is this triangle business? When force is applied to a triangle with rigid rods with hinged corners, there is no movement. A similar four-sided square is easily moved, but when it is converted into triangles, it does not move. Similarly, when we use 6 rods with hinges, it moves, and when it is converted into triangles, it does not move. So this principle is used for huge buildings, bridges, and other constructions like this. And so triangle construct is an engineering miracle. Can it be applied to ortho implants? Yes. Liver et al. Studied cadaveric studies, 5 constructs for proximal humerus fracture, and they found that triangle construct is the strongest. So this principle we applied to fracture neck femur. The plate offers lateral stability. Sleeve prevents toggling of the screws. Lag screws inserted at 90 degrees to fracture line compress the fragments. Triangle provides absolute stability, acts similar to protection plate, protecting lag effect and no sliding. It's an angle stable implant. We have classified the implants into 4 types. One is the uncontrolled collapse, that is DHS and 3 cancel screws. And the newer implants have controlled collapse, Targon-FN, Depusynthesis system, and Conquest. Now there is a large number of necks or length stable implants have come with absolute stability. One is my GSKT system, locking plate, antero-inferior plate, and there are many other including the Filipov method. Continuous compression during post-operative period occurs in Smith and Nephew Conquest. This is a new concept here, and a primary valgus osteotomy. These are the 2 new implants produced by 3 big companies. Depusynthesis have femoral system, Smith and Nephew have Conquest, and Targon. But all of them allow sliding. Now, this is a 60-year-old man had a fall in the field. Note the displacement. This was treated with a DHS, modified DHS, and a triangular system. This is how the plate is. Plate is just a short plate, about 30 millimeters. And you can see this screw, which is inserted here like this, prevents the DHS backing out. This is another case, 38-year-old male nurse sustained fracture neck femur in motorcycle accident. See, there is a global comminution all around, anterior, superior, posterior, and inferior. And this was treated with again a triangular system. And at 8 months, he went back to his work. Our experience is in 38 cases, follow-up is 4 to 30 months, average 11 months. There are 2 non-unions. AVN is too early to predict. Results are very encouraging. So in conclusion, fracture neck femur heals by primary healing with intraoperative compression and absolute stability and no mobility. GSKT system provides both compression and absolute stability. It works on principle of truss construct and engineering marvel. It can be used for other metaphyseal fractures such as IT fractures, proximal humerus, etc. Thanks, WIROC.